We believe that it's those overweight and obese patients with weight-related complications that can best benefit from weight loss therapy, and it's in those patients we need to kind of target our more aggressive therapies so to optimize benefit risk and really proceed in a cost-effective manner. And of course that includes people like in what I call pre-diabetic states, patients with metabolic syndrome or prediabetes. These patients have high risk of progressing to type 2 diabetes, and we know that weight loss is very effective in those patients. There's 3 treatment modalities that we can use, and all of them have had advances in the last decade or so. We have lots of clinical trials showing the effectiveness of lifestyle intervention, intensive lifestyle therapy, and studies that show what components of lifestyle intervention are particularly effective. You know, using a reduced calorie diet according to a healthy meal plan with a macronutrient composition that accommodates the patient's personal and cultural preferences. We don't have to fix that. We have a lot of flexibility, physical activity that they prefer and are capable of doing, starting slow and building on that. Meal replacements we know are effective. That adds a lot of structure to the diet. They know how many calories are in there. Self-monitoring, patients just writing down what they eat and their activity. That alone can lead to weight loss. We have new medications in addition to orlistat that we've had for some time. We have 4 new medications: phentermine, topiramate extended release, larcaserin, naltrexone, bupropion combination, and high-dose liraglutide. Phase 3 clinical trials all show that if you add any one of these medications on top of a lifestyle intervention, you will get more weight loss and keep that weight loss off for, maintain that weight loss for a greater period of time. Yes, they all have, you know, their own profile for side effects and cautions and warnings. It's important that healthcare professionals read the prescribing information because we need to individualize therapy. So we need to match the right person up with the right medication. But you know, by and large, these medications are well tolerated and safe. They've been approved by the FDA due to proven efficacy and safety. Well, it can certainly have that effect. You know, I think, you know, with bariatric surgery it can be very effective. It has its own kind of BMI cutoff and indications where these can be done, which is not, certainly excludes a large number of patients that are overweight or obese that really need weight loss to promote health. But you know, we're really using the ACE approach is what I call complication centric. We're really it's the presence and severity of weight-related complications that are the major determinant of how aggressive we want to be with our weight loss, and including whether we want to use medications in addition to lifestyle intervention. And if we're treating a complication where we need 10% weight loss to really predictably benefit the patient, that includes prevention of diabetes, treatment of sleep apnea, treatment of non-alcoholic fatty liver disease, then we can accomplish that in the clear majority of patients with a lifestyle intervention program and with the inclusion of weight loss medication. So in those instances, bariatric surgery wouldn't be necessary. I think, you know, we're in a transition right now, really culturally, both in the lay public and among healthcare professionals, away from the idea that obesity is a lifestyle choice and towards the idea that obesity is a disease, which of course is consistent with the scientific data. And it's a chronic disease that we need to treat like other chronic diseases: diabetes, hypertension, hypercholesterolemia. You know, so we're coming more and more towards treating it, bringing the full force of our medical model to treating it like any other chronic disease. And I think that's happening. The progress is a little slow, but 10 years from now, I think that's right where we'll be, and we'll be, you know, we'll have additional medications as well. I think eventually, like diabetes, where we combine different medications together, combination therapy to keep the hemoglobin A1C down. We'll be doing the same thing with obesity medications, using these medications in combination. You know, if you think about it, there's a lot of regulatory mechanisms and pathways and hormonal feedback systems that regulate appetite and food intake, and if you can affect multiple pathways at the same time, you're going to have a more effective strategy. You know, like any chronic disease, it's due to an interaction between genes and environment and behavior. The genes are pretty much the same. I mean, our genetic composition changes slowly over time, but over the past several decades where we really have had an explosion in the prevalence of obesity and type 2 diabetes, the genetic background has stayed relatively the same, so it's the environment that has changed. We eat more, we are more sedentary, and you know, I think we have greater access to high caloric density foods, and so I think it's just the changing environment that we need to kind of counteract. Well, again, there's slow progress. You know, I mean, I think usually prevention starts with public education, and the word is out that obesity can impair your health. You know, I think that, you know, the problem is that obesity is a disease, and all of these hormonal regulators of food intake, if you lose weight, the hormones that make you eat more go up, the hormones that make you eat less go down, and even your resting metabolic rate, the amount of energy you're burning just sitting here, goes down, which promotes weight gain. So all these mechanisms are working in overdrive to return that patient back up to that previous high body weight. So that's what patients are fighting against in lifestyle interventions, and why these medications can be helpful, because they work on these neuroregulatory mechanisms.